Welcome to the first session of our meeting today. I'm Bhargavi Gali. I'm the treasurer of SASM. I'm pleased to introduce Dr. Brian O'Gara, who is assistant professor in anesthesia at Harvard Medical School. He serves in the Division of Critical Care and in the Division of Cardiac Anesthesia. As a junior investigator, he obtained an NIH T32 training grant and a FAIR mentored research training grant. He has done work on the use of volatile anesthetics in alternative settings, and additionally has been working on novel technology for use in the perioperative period. Specifically, he received the John Hedley White Award to evaluate the effect of a preoperative cognitive training program on postoperative neurocognition and delirium. He is also in the process of evaluating virtual reality as an adjunct to monitored anesthesia care in the perioperative arena. He is the program director of the Anesthesia Resident Research Program, mentoring young clinician researchers. We look forward to his talk.
Hello, everyone. My name is Brian O'Gara. I'm an anesthesiologist at the Beth Israel Deaconess Medical Center in Boston, and today I'm going to talk to you about the importance of sleep and perioperative neurocognition. This is my disclosure slide. So as many of us know, especially in the anesthesia field, our patients are getting older. Their medical complexity is also getting more complex. And as they show up for surgery, one of the most important focuses for the next coming years is to try and reduce postoperative complications. And of those, delirium and postoperative neurocognitive disorders are very important. So we know that in-hospital delirium is associated with an increased risk of postoperative complications, poor postoperative functional recovery, and is associated with higher in-hospital mortality. And we also know that complications such as delirium are associated with dramatic increase in excess costs to the healthcare system. So very important to prevent. Now, we published recently, those of us at the Beth Israel, colleagues from the Mass General, published a review in anesthesiology that I would encourage you to read, which forms the basis for this talk. I would like to give a shout out to Lei Gao, who is responsible for most of the content on the sleep section, which we are going to talk about today. Sleep as an intervenable target to prevent postoperative neurocognitive disorders. So as those of you in the society probably know better than me, there are 5 dimensions to sleep help, and most of these dimensions can be affected by surgery, anesthesia, postoperative recovery, stay in the intensive care unit. And although many of us in the field recognize the importance of sleep and the disruptions that the hospital environment can have on our own sleep, there's been few investigations into whether or not these disruptions can actually be causative factors for postoperative complications, including delirium. So this figure kind of summarizes what we're going to talk about today. Basically, you have patients who bring to their surgery underlying neuropathologic conditions such as dementia, Alzheimer's disease, obstructive sleep apnea that can modify the relationship or even have a causative relationship for sleep disruptions, circadian rhythm disruptions, which then can be exacerbated in the perioperative period. There have been some interventions that have been proposed to try and prevent this relationship, this disruption of sleep disorders and perioperative neurocognitive disorders, including delirium, and we'll talk about those in more detail. So in terms of preoperative sleep disruption, we do know that from studies of patients who are wearing things like actigraphy devices in the preoperative period, that those who have a higher percentage of preoperative sleep disruptions are at an increased risk for delirium. In fact, of a meta-analysis of about 1,200 patients for multiple small prospective trials, mainly those with a higher number of these disturbances, such as the percentage of time spent awake after sleep onset and the number of nightly awakenings, have a greater risk, a much higher risk, odds ratio over 5 of developing postoperative delirium. And that sort of brings to mind the question of whether or not the preoperative sleep disturbances are causative factors or merely reflections of other underlying processes. Can the sleep disruptions either cause or be markers for altered melatonin metabolism and neurotransmitter imbalances? Can there be reduced cognitive reserve from sleep disturbances? And do some of the comorbidities that we know cause sleep disturbances, such as heart failure, obesity, obstructive sleep apnea, can those things be causative factors for delirium as well? As of yet, that question is not answered. So sleep disordered breathing, especially sleep apnea, is a very hot topic in anesthesia. Patients with obstructive sleep apnea are at increased risk for highly morbid complications, problems with postoperative respiration, delayed emergence. And we know that in some of our trials, the patients with sleep apnea are at higher risk for delirium as well. So either patients who have known diagnoses or are wearing devices that can determine their apnea-hypopnea index, patients with higher risks have been found to have higher incidence of delirium in sort of smaller prospective cohorts. The one at the bottom there was a large retrospective cohort where they did a pretty thorough job of adjusting for confounders for the development of delirium, such as age, baseline cognitive dysfunction, length and type of surgery, et cetera. And there was no association found between patients with sleep apnea and the risk for postoperative delirium. So given that we may think that sleep apnea can be a risk factor for the development of postoperative delirium, can the treatment, or at least the intervention that is supposed to ameliorate the pathophysiology of sleep apnea and disrupted sleep, can CPAP, namely, prevent delirium? So there has been one small trial that we recognized in the review of patients who are at risk for sleep apnea. There were adults who were scheduled for non-cardiac surgery. And these patients were randomized to either wear CPAP before and after surgery or not. And although the investigators found that your preoperative AHI was significantly correlated with your delirium severity, and that for patients who had increases in their postoperative AHI from baseline had worse severity of delirium, there was no difference found between the patients who wore their CPAP and those who did not in terms of the incidence of delirium. Although it should be noted that just like in the real world, patients in the study did not wear their CPAP very often, so only 3 nights before surgery and 1 night after surgery. In terms of pharmacologic interventions, dexmedetomidine gets a lot of attention in the ICU, especially for sedation. It's been found in some of our large sedation trials to be less deliriogenic, especially when you compare it to benzodiazepines. It is sort of debatable whether or not it is less deliriogenic than propofol. However, we do know from some physiologic studies in healthy volunteers and also in ICU patients that of all the sedatives that we commonly use for mechanically ventilated patients, dexmedetomidine does sort of mimic natural sleep in terms of EEG and the duration of non-REM sleep, more so than things like midazolam and propofol. And we do have data from one large randomized placebo-controlled trial in 700 patients in China having surgery, non-cardiac surgery, whereas patients in the dexmedetomidine group were given dexmedetomidine for the first night after surgery until 8 a.m. the morning after, as opposed to placebo, that those patients had a greatly reduced risk of developing postoperative delirium and reported better sleep quality. Now, this sort of dramatic of an effect was something that was a little hard to believe for many investigators in the field, given that other pharmacologic interventions have not been shown to produce such an effect. And one of the reasons why, at least suspected, why promoted as a possible thing that wasn't measured in the study, was maybe the dexmedetomidine was turning many patients with agitated delirium into hypoactive delirium, which is much more difficult to pick up in typical assessments for delirium. So something to be aware of there. Melatonin is another drug that is commonly used in the general population as well as in the ICU to try and promote better sleep. I probably would be making a mistake to try and teach the audience about melatonin and its effects on sleep. But I will say that there have been some studies of urine metabolites of melatonin and serum levels of melatonin that does suggest that its levels are decreased in patients with delirium. And so therefore, for many reasons, melatonin has been studied in terms of a preventative agent for delirium in ICU patients. And in surgical patients and cardiac surgery patients, there's been some mixed data for melatonin in terms of having a benefit, and then no benefit for Ramelteon. And there's been so many trials that in 2020, there's a meta-analysis of 16 of them. And that group there found that there was not sufficient data to support a benefit of either melatonin or Ramelteon to prevent delirium, because the data was mixed. And I think that a recent trial that came out sort of illustrates the potential lack of a benefit for melatonin, and that was the ProMedic trial, which came out this year. And so this was a trial of over 800 patients in the ICU. And the primary outcome was the proportion of delirium-free assessments. As you can see here on their table 2 for their results, there was no difference between groups in the number of assessments, which were negative, so roughly 80% in both groups, or in the number of assessments that were positive, the severity of delirium, the percentage of delirium-free assessments per patient, the amount of patients requiring antipsychotics, or the overall 28-day mortality. And these figures sort of show that in more graphic detail, of course. So that on the left, we have the percentage of delirium-free assessments in patients with melatonin, which is in light green, versus placebo, which is the dark green. And then on the right, we have our Kaplan-Meier curves with survival all the way out to day 90, and no difference between groups in either outcome. So in terms of the impact of melatonin supplementation on sort of longer term postoperative cognition, there are 2 trials that we can look at. One was an RCT of patients undergoing hip surgery, where they gave them melatonin the night before surgery, and then for the next 5 nights in the hospital or out of the hospital if they were discharged by then. And they did find that patients in the melatonin group had higher MMSE scores on days 1, 3, and 5, but the scores were similar on day 7. And it should be noted here that sort of postoperative cognitive decline or delayed neurocognitive recovery was not defined as a decrease from a baseline score in this study. So just a difference in the raw mini-mental status exam scores on 1, 3, and 5 were measured here. So it's unknown whether or not there's an actual clinically relevant benefit here for melatonin. And then there was another RCT of patients undergoing breast surgery, in which they actually gave the melatonin for a month before surgery and 3 months after surgery to try and really get a dramatic effect of sleep over a long period of time. And unfortunately, they didn't find any difference in the rates of delayed neurocognitive recovery or postoperative neurocognitive disorder at 3 months. And then lastly, given what we know about the effective interventions to prevent delirium, most of those to date are non-pharmacologic, non-procedure or surgery or anesthesia-related factors. And so there has been efforts made to try and create non-pharmacologic sleep-related bundles with mostly environmental interventions, giving patients eye masks, earplugs, playing some soothing music, reducing nighttime interventions such as the amount of overhead pages or having the television on, doing some other nice things like giving patients a warm bath before they go to sleep, or controlling the room temperature and controlling their pain. So as you can see here from one trial, it was a before and after trial of 300 patients in the medical ICU, that the team was very adherent to most of these interventions. Some of them were easier to achieve than others, such as preventing unnecessary alarms, as opposed to achieving the amount of overhead pages as none at night. But in this before and after trial, they did find a dramatic reduction in the after group for the incidence of delirium. So something to keep an eye on there, and perhaps implement at your own place. So in conclusion, we know that perioperative sleep disturbances are contributing factors to postoperative delirium. However, the interventions that are used to either improve sleep or to prevent the physiologic effects of things like sleep apnea have not been shown to be effective in reducing delirium to date. We need to perhaps, like we've looked at for other interventions to prevent delirium, see how these interventions that are looking at isolated predisposing factors or precipitating factors, how they are effective when used in a bundle of interventions, as opposed to a single intervention in and of itself. And then there's also a need for a lot more research into the effect of perioperative sleep disruption and these proposed interventions to improve perioperative sleep. What type of effect these things have on long-term postoperative cognitive dysfunction. Thank you very much for listening.